Hello everyone, welcome to Bleeding and Coagulation Disorders in Children. This is one topic where I'll try not to go into the physiology and pathology part, but give you the clinical context, the clinical correlation, and scenario-based approach for your exams. I personally feel this is the way exams are evolving, and we as students, as teachers also need to evolve accordingly. So let us start with approach to bleeding disorder in children. So let us make a handmade approach. If there is a child who comes to you with bleeding, there is broadly two possibilities, two types of scenarios examiner will mention. The first type of possibility will be the child is coming to you with features like non-palpable petechiae and purpurae. So there will be pinpoint bleeds like petechiae and purpurae, but they are non-palpable. Remember that palpable petechiae goes in favor of Henoch-Schwann and purpura, which is a vasculitis. That is not being discussed here. Then the examiner will say there is mucosal bleeds. So mucosal bleeding will be there. There will be prolongation of bleeding time. But the coagulation test like prothrombin time and activated partial thromboplastin time will be normal. If you have a presentation like this, the patient is likely to have a platelet cause of bleeding. So the cause of bleeding is platelet cause. On the other hand, in case examiner says that there is a child with deep ecchymosis, ecchymosis are large confluent areas, the patient is having systemic bleeds. Systemic bleeds means there are deep-seated bleeds which are happening, particularly hemarthrosis, bleeding inside the joint. Hemarthrosis is bleeding inside the joint, and muscle hematomas. They may have epistaxis in a few patients. Sometimes epistaxis will be present sometimes. Bleeding time in these patients will be variable. Variable means it may be increased, it may be normal, it may be abnormal, and PT and APTT are affected. In such patients, you will think that the child is suffering from coagulation cause of bleeding. So we have two types of causes of bleeding. We have the platelet cause and we have the coagulation cause. Let us first take the platelet cause. If it is a platelet cause of bleeding, there are two possibilities which should be considered. In case the examiner says that platelet cause is there, then if the number of platelet count is low, you look at what is the associated abnormality. Number low means thrombocytopenia. So this is nothing but thrombocytopenia. If the size of the platelet is normal, you should suspect a ITP-like condition. ITP stands for immune thrombocytopenic purpura. But if they say the size of the platelet is small, size of the platelet is abnormally small, and they write it is associated with rash and recurrent infections, such patients you will suspect a disorder called as Wiskott-Aldrich syndrome, and this will generally be seen in males because it is an X-linked recessive condition. So these are the possibilities you will consider if it is a low platelet count. On the other hand, in case the platelet, this type of presentation is there, but the platelet number is normal, you will suspect the child is suffering from platelet functional defects. There are two types of platelet functional defects. You have Bernard-Soulier syndrome and you have Glanzmann's thrombasthenia. These are the conditions that should be suspected. And when you talk about coagulation cause of bleeding, there can be possibilities like hemophilias. Hemophilias can be there. Patient can have von Willebrand disease. You can have liver disease. And you can have vitamin K deficiency. And lastly, the patient can have DIC. How to distinguish between them? As we discuss, we shall be progressing. So have a look here. This is the overall approach. It is a symptom-based approach that you need to follow when you are solving MCQs. Let us discuss the individual things, the important individual things one by one. Let us first talk about platelet disorders. So I'm giving the heading platelet disorder. I will be very brief. I will not go into the hematology part. I will go into the clinical part. In platelet disorder, the most common platelet disorder found in children, most common cause seen in children is acute ITP. Remember that chronic ITP is a disease of the adults. ITP stands for immune thrombocytopenic purpura. Earlier, we used to have a condition called as idiopathic thrombocytopenic purpura, but the term idiopathic is no longer used because we now know it is an acute manifestation, and these patients have an autoantibody formation against the platelet. Acute ITP is said to be there where the onset of illness is less than 3 months. 3 to 6 months is generally considered to be subacute, and more than 6 months is generally considered to be chronic ITP. So onset is for 3 months duration. It is not age. Onset is less than 3 months of duration. Now, what is the peak age in which acute ITP happens? It is 1 to 7 years. And what is the cause? It is often triggered by a non-specific viral infections. What happens is that there is a viral infection. After a viral infection, there will be onset, there will be development of autoantibodies against platelet antigens. Particularly, there is a platelet antigen called as glycoprotein 2b3a. This is present on the platelet surface, and this autoantibody will be it will attach to the platelets. These antibody labeled platelets will be destroyed in the spleen because this antibody is circulating in the blood. So even if you try to give platelet concentrate or platelet transfusion, it will not be effective because antibody will then bind to the transfused platelet and they will also be destroyed by the spleen. And that is why acute ITP patient, there is no real use of giving platelet concentrate. If you understand this particular thing, then it explains why platelet concentrates are not a favored agent for acute ITP patient. Now, acute ITP, how does the patient present? Clinically, these patients will be young kids, otherwise normal. There will be an acute infection, generally a viral infection. It can be respiratory, rarely it can be GIT. About 1 to 4 weeks later, there will be onset of petechiae and purpurae. Onset of petechiae and purpurae plus minus mucosal bleeds. So oral mucosa and nasal mucosa, there may be some bleeding happening rarely. Remember that these patients, there is no lymphadenopathy, no organomegaly, that is hepatosplenomegaly ever seen. No lymphadenopathy, no hepatomegaly is seen. So they should always, if they are present, ITP should be ruled out. So no lymphadenopathy, no hepatosplenomegaly is ever present in these patients. Now, what is the treatment that you give? Treatment is generally conservative or supportive. Most of these patients, there is a dip in platelet count somewhere around 25 to 50,000 and then it automatically improves. If it is severe, that is less than 10 to 20,000 and associated with bleeding, then you need to consider drugs. If there is serious clinical bleeds, you need to consider drugs. The two options you have, you can go for IVIG or you can go for oral corticosteroids. Dexamethasone or prednisolone can be given for 5 to 7 days. Some patients benefit from anti-D also, but you need to make sure it is a Rh rhesus positive patient that you are using. So the two first-line drugs which are approved for use by American Society of Hematology, it is IVIG or oral steroids given for 5 days. So this is your key points are discussed about the topic of acute ITP. Remember, chronic ITP occurs in adults. Chronic ITP is the one where splenectomy will be needed, and thrombopoietin agonists are also indicated in chronic ITP, but they do not have any role in the childhood ITP. Then we have the so-called platelet functional disorders. We have the platelet functional disorders. Two types of platelet functional disorders you already know. We have Bernard-Soulier syndrome and we have Glanzmann thrombasthenia. Glanzmann thrombasthenia. Bernard-Soulier syndrome, I'm writing it short as BSS. And Glanzmann thrombasthenia, I'm writing GT. Now, Bernard-Soulier syndrome is a condition in which there is abnormality or absence of glycoprotein 1b9. So it is a glycoprotein 1b9 defect, because of which there is defective platelet aggregation, platelet adhesion. So adhesion is found to be defective in these patients. Whereas in Glanzmann's thrombasthenia, there is a defect in glycoprotein 2b3a. And because of this, there is a difficulty in platelet aggregation. So there is defective aggregation. If you are suspecting both of them, the test that you should be performing is called as Ristocetin aggregation test, also called as simply Ristocetin test. If the Ristocetin test is found to be negative or abnormal, then Bernard-Soulier syndrome should be suspected. If it is found to be positive, which is a normal test, you should suspect Glanzmann's thrombasthenia in the patient. Then among the coagulation disorders, sometimes questions are asked related to von Willebrand disease. Von Willebrand disease. Von Willebrand disease is also written as small v, capital V, capital D. Von Willebrand factor is a carrier of factor 8, and the von Willebrand factor is also involved in platelet function. So you will have a mixed bleeding plus coagulation kind of picture appearing in such patients. First thing, von Willebrand disease is considered to be the most common inherited cause of bleeding in children. People tend to think it is hemophilia. No, von Willebrand disease is actually more common. What is the type of inheritance seen? It shows autosomal dominant inheritance. So autosomal dominant inheritance is shown in patients of von Willebrand disease. There are multiple subtypes of von Willebrand disease which have been described. So we have type 1 von Willebrand disease. Type 1 variety, it is the most common form. There is reduced levels of von Willebrand factor. And these are the patients who will be benefited. They respond to therapy with desmopressin. Desmopressin has been shown to increase the levels of von Willebrand factor in type 1 form. Then we have type 2 von Willebrand disease. Type 2 has multiple subtypes. All of them have reduced activity of von Willebrand factor, even if the levels are not less. In type 1, the levels of von Willebrand factor were low. Here the activity is low. It is of further 4 types. You have type 2A, 2B, 2M and 2N. Among them, it is the type 2B, which is the variety which is associated with thrombocytopenia. So these patients have additional problem of thrombocytopenia. And then we have type 3 von Willebrand disease, which is considered to be the most severe form. And these patients will have absent von Willebrand factor. And you will have to give von Willebrand factor concentrates should be given as part of therapy. So these are the subtypes of von Willebrand disease that you should know. Treatment needs to be individualized. As I said, desmopressin will be useful in type 1. It will be ineffective in type 3, and in fact, some varieties of type 2, it is contraindicated. It does not produce a benefit. Instead, it can cause more abnormality in the patient. Now, why it causes more abnormality, that will depend upon the individual subtype. This is one area where, going into details in the PG entrance exam is not needed. But you need to remember that whenever von Willebrand disease is given in the question, clinical suspicion or MCQ suspicion should occur if it is either male or female, because it can occur in both genders. There will be epistaxis mentioned. If it is a girl, they will mention menorrhagia. These are the buzzwords. These are the keywords you need to watch for. And they will say there is prolonged bleeding after surgery. Prolonged bleeding after surgery. And in these patients, prothrombin time will be normal. Activated partial thromboplastin time will be mildly increased. And bleeding time will also be increased in 50% of the patients. but remaining 50% it will be normal. So these are the clues. In fact, there is already a MCQ asked on this particular information in the July 23 paper of FMG entrance exam. So similar question has been put in the Q bank also. So this is regarding the von Willebrand disease. And then we come to the topic of hemophilias. Hemophilia is a topic that is discussed in multiple systems. So all I will focus on are the summary of hemophilia points that you need to know. Now, hemophilias are coagulation disorders characterized by deficiency of the clotting factors. Now, clotting factors, there are two types of pathways which are there. Coagulation pathway, we have extrinsic pathway and we have intrinsic pathway. Because factor 8, factor 9, they are involved in the intrinsic pathway. So you have elevation of activated partial thromboplastin time found in them. Hemophilias, there are three varieties. Most common is Hemophilia A, which occurs due to factor 8 deficiency. Second variety is Hemophilia B, which occurs due to factor 9 deficiency. Factor 9 is also known as Christmas factor. So this disease is also known as Christmas disease. So which disease is known as Christmas disease? It is Hemophilia B. Both factor 8 and factor 9 deficiencies are X-linked recessive, and so only boys are affected. Men are affected, girls are only carriers. But there are rare forms of hemophilias also. We have Hemophilia C. Which occurs due to factor 11 deficiency. And this condition is autosomal recessive, so can occur in both boys and girls. And then there is an even more rarer form called as parahemophilia, which behaves like hemophilia under circumstances, but per se does not cause spontaneous bleeding. It occurs due to factor 5 deficiency. And just like Hemophilia C, this is also autosomal recessive and can occur in both boys and girls. But when we generally talk about hemophilia, we are talking about these two varieties. Now, what is the clinical findings, clinical picture that you need to remember in hemophilias? So, patient will have deep-seated bleedings, they will have ecchymosis, they will have hemarthrosis. Recurrent hemarthrosis in a joint is called as target joint. And the most commonly affected joint as a target joint is the knee joint. And knee joint, due to repeated bleeding into one joint, can lead to the development of hemophilic arthropathy in the later stages. And hemophilic arthropathy is deforming arthritis which occurs when bleeding occurs, and then there is accumulation of hemosiderin. Hemosiderin in the joint causes chronic inflammation and deformity. And that is the mechanism of how hemophilic arthropathy tends to occur in the patient. Now, when you do investigations in hemophilias, what pattern you will see? You will find that bleeding time is normal, prothrombin time is also normal, but activated partial thromboplastin time will be increased. And then to identify the type of coagulation parameter, you need to do individual factor levels also. They need to be assessed in the patient. Now, coming to treatment of hemophilias, you need to do the best therapy available is factor replacement. Factor replacement. How much factor needs to be given in case of hemophilia A? The factor 8 requirement can be calculated by the formula percentage desired rise in the factor, in factor level, multiplied by body weight, multiplied by 0.5. And in patients with hemophilia B, the formula will be factor 9 requirement can be calculated by the formula percentage desired rise multiplied by body weight multiplied by 1.4. So the distinguishing point is 0.5 here and 1.4 here. And how much desired rise will be needed? If it is mild to moderate bleeds, the rise needed is between 30 to 50% of the total levels of the factor. But in case of CNS bleeds, you want to have 80 to 100% of the bleed. So this is how you are going to calculate how much factor is needed. But the problem is that factors are costly and they're not always available. Put a star and write, if factor replacement, if factors are not available, you can go in for blood products, second line therapy. So first line therapy is factor replacement. Second line therapy will be fresh frozen plasma, followed by cryoprecipitate. Remember that fresh frozen plasma will be applicable in both hemophilia A and B, whereas cryoprecipitate will be applicable only in hemophilia A, because cryoprecipitate does not have any factor 9. And so remember, there are some variations you should know. If the examiner says there is a patient with bleeding time increased, prothrombin time increased, and activated partial thromboplastin time increased, what should be suspected? This is a scenario that we are discussing. So you should be suspected that there is DIC or liver disease or late vitamin K deficiency, which can present like this. But if examiner says BT is variable, prothrombin time is increased, but APTT is normal, in such patient, what will you suspect? You will suspect either factor 7 deficiency or you will suspect early vitamin K deficiency. So this is the overall clue and the overall clinical picture related to bleeding and coagulation disorders that you need to know. Thank you.